Welcome to our SNA Radiographics podcast. I'm Dr. Natalia Secaroni Ortman, a breast radiologist from Brazil. Today, together with my co-authors, I will be discussing our 2025 Radiographics article, Breaking Bad News, a Common Protocol for Radiologists, in which we introduce Red News, a 7-step framework designed to help radiologists to navigate one of the most challenging aspects of clinical practice, delivering difficult news to patients. This work has a personal origin. Early in medical school, during an emergency rotation, I struggled to communicate a patient's death with compassion that moment deserved. Later, in my radiology residency and fellowship, I watched colleagues deliver difficult news with empathy and clarity, and I realized that every radiologist can blend technical precision with genuine compassion. Those experiences led me and my colleagues at INRAD, the Institute of Radiology of Hospital das Clínicas, University of São Paulo, Brazil, to transform what we had learned intuitively through trial and error into a scientific framework grounded in evidence-based research. It has since evolved alongside our team across various institutions and truly reflects a collective effort. I'm delighted to share these conversations with the colleagues who made it all possible. Joining me today are Dr. Lídia Rodrigues.
Hi, everyone.
Dr. Érica Endo.
Hello.
Dr. Natália Tavares Lima.
Hello, everyone.
Dr. Vera Ferreira.
Hi.
Dr. Carlos Chimizo.
Hello, I'm here.
Each bring their own experience and a perspective for their work background. Let's get started. Dr. Lídia, you and Dr. Juliana were the first colleagues I shared this idea with the very beginning of what would become this project. Can you tell us a little about that moment and what drew you to embrace this work from the start?
Yes, I remember that day. You were still in your breast radiology fellowship and you asked about the oranges of my communication style, who had guided me through difficult conversations and taught me to navigate complexity with patients. Almost natural to me, and I took pleasure in perfecting it. I had never explored the theory behind the practice. Instead, I learned it by observing the different manners of my mentors, piecing together a style of my own. Our talk that day highlighted a striking reality. Communication is a missing link in radiology training, a gap that directly impacts how we connect with our patients every day.
Our article opens with an important reframing of what bad news actually means in healthcare. It's not just a terminal diagnosis. Can you walk us through how we define bad news in the radiological context and why the broader definitions matters?
Today, we define bad news in healthcare as basically any information that seriously changes how a person looks at their future. It's a heavy moment, a real turning point for both the doctor and the patient, and it completely shifts the dynamic of their relationship. In radiology, we deal with this much more often than people realize. It's not just about tough diagnosis, like a miscarriage or a disease progression. It's also in those smaller but still stressful moments. It's telling a patient they need a biopsy for a suspicious finding, or calling them back because of a technical issue with their scan. It even happens in interventional radiology when we have to talk to a family member about a complication during a procedure. It's part of our daily reality.
Dr. Carlos Chimizo, radiologists aren't typically the ones patients think of when they image receiving difficult news. And beyond that, radiology doesn't operate in isolation. So, what makes it especially unique when delivering difficult news, and what is the radiologist's role in that conversation?
Firstly, would like to say that Red News was an article idea of our present presentator, Dr. Natalia Ortman, that had this very good idea and brought the project ahead. So congratulations, Natalia, for the job. And about the question, Red News is a start point in containing guidelines on how to handle specific situation. We must understand that it's not a rigid set of rules to be followed to the letter. Some situations in medicine are very diverse and require contextualization and adaptation by the physician, especially considering the professional diversity and the cultural differences across our countries. The innovation of Red News in radiology lies in bringing to the forefront a discussion that's not part of our understanding routine and that we do not frequently practice in our daily work. We hope it serves as an incentive for radiologists to move beyond the usual. I cannot discuss this. I suggest you speak with the physician who ordered your exam. One way I find it particularly effective for improving in this area is to talk with more experienced radiologists about situations where they had to deliver difficult news. Furthermore, it's invaluable to consult with specialists in other fields such as oncologists, surgeons, and obstetricians who frequently deal with delicate situations, asking for their perspective on how they would handle the scenarios we encounter.
Dr. Natalia Tavares Lima, let's walk through Red News step by step. Can you guide us through each letter of the mnemonic and bring it to life with a clinical example, please?
Red News is a mnemonic that organized the delivery of bad news into 7 steps, helping radiologists approach this conversation in a clear, empathetic, and organized way. I will illustrate this with a very common scenario. A patient comes in with a palpable breast lump. She's already quite anxious, especially because of a family history of breast cancer. During the ultrasound, we identify a highly suspicious mass consistent with a BI-RADS-5 assessment, along with suspicious axillary lymph nodes. In letter R, we recap the clinical context. Before speaking, I take a moment to review the situation. This is a symptomatic and anxious patient with a relevant family history, which adds emotional weight to the conversation. In letter A, the ambience and self-introduction. I make sure we are in a private space, comfortable seating. I sit at eye level and introduce myself in a calm and welcoming way. In letter D, I describe the exam and its purpose. I briefly restate why the patient is here, saying, you came in today because of this lump you felt, and our goal here is to better understand what this finding means. In letter N, I notify with clarity and empathy. When sharing these findings, I aim to be clear, but also gentle, saying, during the exam, we found an area that needs further evaluation. Based on what we see, it's something concerning, and we do recommend a biopsy. At this stage, I avoid technical terms like BI-RADS. And in letter E, ensure empathetic engagement. I pause, observe the patient's reaction, and recognize it, saying to her, I understand this is difficult to hear, especially given your family history. In letter W, I welcome questions and share next steps. I then guide the next steps, saying the next step here is to perform a biopsy as soon as possible, so we can reach a diagnosis and decide the best treatment. And I invite questions, saying like, do you have any questions right now? In letter S, stressful reactions may occur. I stay present and supportive, knowing that emotional reactions are expected, without minimizing concerns or causing unnecessary alarm. Ultimately, Red News help us balance 2 key goals: being clear enough to ensure proper follow-up while remaining empathetic, so the patient feels supported rather than too distressed. Because in the end, it's not about just delivering the news. It's about how the patient leaves that conversation.
Dr. Erica Endo, these steps focus a lot on the patient's emotional response. But what about the radiologists? What should we do when the emotional weight of a difficult conversation becomes overwhelming?
It's completely natural to find the emotional weight of this conversation overwhelming at times. If the emotional burden of a thought conversation starts to feel like too much, it is vital to remember you don't have to carry it alone. So, First and foremost, give yourself permission to seek help. According to source, you should feel empowered to reach out to a colleague for support and even delegate the entire discussion to someone else if you feel you cannot manage it effectively. However, if you are on your own, being transparent is a powerful tool. It is actually recommended to admit to the patient that you are feeling uncomfortable with this situation, as this honesty helps maintaining a strong, trustworthy doctor-patient bond. Toward hopeful, practical next steps such as follow-up appointment or a biopsy. Using a structured roadmap like Red News provides the necessary balance of empathy and assertiveness to navigate these difficult moments without losing your footing. Beyond that, I find it helpful to fall back on our training to stay grounded, pause, and recess. If the room starts to feel heavy, take a moment, breathe. Use the pause to recess the patient's nonverbal cues and your own posture. Second, redirect blame. If a patient's stress turns into blame, don't feel you have to validate the emotion. A simple, hopeful pivot like, this would not be the best time to discuss this. So let's focus on the next steps. Can help de-escalate the emotional tension for both of you. And third, remember, preparation is key. Before even walking into the room, review your communication strategy and patient's clinical context. Having a mental roadmap like the Red News protocol, which emphasizes empathy and clear next steps, can provide a sense of structure that keeps you from feeling lost in the emotional moment. And remember that while the news might be bad, your presence and your ability to offer a hopeful, empathic path forward is a fundamental part of successful therapy. Taking care of yourself in this moment is what allows you to continue taking care of them.
Dr. Eka, for the regulars listening, what does a well-handled conversation look like in the room? The setting, the body language, the tone, what makes the difference?
As Dr. Natalia Tavares already said, that's such great question. For those of us often tucked away in the reading room, it is easy to forget that physical and emotional space we create is just as vital as the diagnosis itself. In a well-handled conversation, the setting is the first thing that makes a difference. You want a welcoming, well-lit environment where the patient is positioned comfortably at the eye level with you to allow for easy visual contact. This simple alignment helps move the dynamic away from a passive receiver of news to a shared experience where everyone is on the same wavelength. When it comes to body language, the sources emphasize maintaining an open posture, which means avoiding barriers like crossed arms and legs. As radiologists, we need to be active observers. A successful conversation involves constantly monitoring the patient's nonverbal cues like nodding, crying, or even a look incredulity, so we can adjust our approach in real time. If a patient is visibly distressed, even a gentle touch on the hand or shoulder or a simple nod while they speak can provide immense comfort. The tone should be a blend of precision and warmth. We should speak with assertiveness and clarity, using simple language rather than dense medical jargon, while maintaining a gentle, measured pace that offers reassurance. The goal is to convey support and instill hope, even when the news is difficult. Ultimately, don't forget Rad News Protocol. Remember, a well-handled conversation doesn't just deliver a result, it recaps the clinical context, validates the patient's emotions without dismissing them, and always close with a warm farewell and a clear explanation of the next practical steps. This structured but empathic approach is what transforms a clinical encounter into a cornerstone of successful therapy.
Dr. Vera Ferreira. And on the flip side, are there specific phrases of or framing that constantly help patients process difficult information? And what are the most common pitfalls we see?
There are no set phrases, unfortunately. The most important thing is to understand the patient, their clinical and psychological context. A major problem I observe is that we, radiologists, often don't know the patient before the exams, and it is frequently at these moments that we need to deliver the news. So, each patient is unique and must be respected in their individuality. People receive and process news in very different ways, and the same words can be understood differently depending on their life context and previous experiences. The most important thing, Natalia, I think, is not the phrases, is to keep in mind who is receiving it. Clarity and honesty are essential pillars that should guide us in this process. Regarding news about breast cancer screening and diagnosis exams, it's important to state that not all finds will be malignant, that this is an opportunity to make diagnosis in early stages, treat and cure, and that we will be always available. And finally, after give the news, we could ask, would you like me to explain anything again?
Dr. Carlos Chemizo, as a final thought, is there anything in the article that we would like listeners to pay special attention to, or a key message we want to leave with our audience?
In general, the radiologist is not the physician who provides the final diagnosis, determines the clinical course, or administers treatment. Most often, patients' interactions occur within a report room, like a consultation office, at a radiology clinic, or even during an ultrasound, where time for conversation is very limited. This is quite different from the typical office setting where clinicians and surgeons operate. Despite not having specific training in outpatient management during our residence, we frequently encounter situations where patients seek additional information about the exams they have just completed. This is perhaps one of the greatest challenges we face when delivering bad news. In this context, we must understand that radiology is part of a multidisciplinary team, and our role is a vital step in both diagnosis and treatment. Furthermore, we can and should provide the information necessary to address our patient's question. Contrary to what we might imagine, resolving a patient's doubts regarding their exams can actually result in less anxiety and great comfort. Communicate findings clearly without causing excessive anxiety or leaving the patient in despair is a key element of the process. It's equally important to emphasize that the patient is the necessity of following up with their referring physician when required. Furthermore, patients often feel much more supported when we inform them that we will discuss their case directly with their primary doctor to share the specific detail of the exam.
Many thanks to you all for such an insightful conversation. To everyone tuning in, thank you for joining us today. We hope Rad News can make a genuine difference in how radiologists connect with this in their care. You can read the full article at Radiographic's website. Until next time, bye bye.